Today's episode is one that I wish that I could listen to on the day we got McRae's diagnosis. If you're a newly diagnosed CDH parent or you love somebody who is stepping into this world for the very first time, then this episode is for you. I'm going to walk you through congenital diaphragmatic hernia, or CDH, in simple, human, easy to understand language to the best of my abilities. No medical degree needed, just honesty, clarity, and the heart of a mother who's lived it. My goal is for you is to finish this episode feeling informed, grounded, and less alone. Welcome back. I know it has been a minute. It has been a minute. You know, it's the holidays. I could come up with a million excuses. Me being emotional, not having Thanksgiving with McRae and Christmas and all of that, or the fact that his twin sister threw my phone into the swimming pool and I had to wait weeks to get a new one because I wanted one with large storage so I can re-download all my pictures that I do have of McRae. But it doesn't matter because I'm here. I'm recording this today and you're listening to it. So hopefully we are getting back in the swing of things. So that's that. So for this episode, I want this to be my first syndrome spotlight or condition spotlight, whatever you want to call it. I can't come up with a catchy name yet, and I don't even know if I ever will. But this is a huge goal of my podcast where I want to be a resource for medically complex parents. I want to create a community. I want you to be able to look up a condition if your baby or you know someone's baby who just got diagnosed with this super rare, never heard of thing, and they come to my podcast and they can talk to a parent who has been through that, can help, can tell you good hospitals for that. And that's just a huge part of why I did this podcast, because when I first started looking up stuff about CDH, I couldn't find anything. Thank goodness that there was a Facebook support group, because that's how I found his incredible surgeon, because I was advocating for him when I was pregnant, when his maternal fetal medicine team was not. They were very, very adamant about a reduction or the feto procedure, which I'm going to get into that later. So CDH is congenital diaphragmatic hernia. So sorry, let me just say, let's get started. If you just found out that you had the diagnosis, I'm here. If you have a friend on your Facebook that just found out they had the diagnosis, you know, send them this podcast. I really, really hope that it could help. So CDH stands for congenital diaphragmatic hernia. Basically, that means that the baby's diaphragm, it's so funny because I remember going into my diagnosis with McRae, they were like, he has gastroschisis. And we were like, okay. And I said this in my first episode. I was like, that's cool, gastroschisis. Like that is what he has. Or an omphalocele. You can't tell. They could not tell yet. But they're like, we see his intestines. And I do remember his umbilical cord being like super thick. And, you know, later I find out that whenever they were first looking at him and thought all of that was going on, and he got misdiagnosed with gastroschisis, your intestines actually form outside of your body, which is another reason why doctors wait till later for anatomy scans, because they go into your umbilical cord, and they twist and do the thing that they're supposed to do, and then they go back into your body, back through that cord and the way that they are supposed to. And I'm saying all this because he didn't have gastroschisis, but they thought he did. And CDH is kind of like that in the sense of the intestines didn't form the way that normal babies do. And so kind of like a gastroschisis baby, they, you know, science has to be involved, and they have to either with gravity, like they'll make a sac or something to have the intestines go back in and hope that they go the way they're supposed to. But in CDH situation, they are pulling them out of the chest cavity and putting them back into the like belly area. But so let's get back to it. So the diaphragm is a muscle that separates your chest from your abdomen. And when it doesn't form correctly, is what they tell you when you're getting this diagnosis, there's typically a hole or absence of muscle. They'll say it different ways. And because of that, the organs like the stomach, intestines, sometimes liver, spleen, all the things can move into your chest where the lungs should be growing. So think about it like a 2-story house in space and like stuff is floating everywhere. Well, you know, if you have the 2 floors separating it, your downstairs things are going to stay downstairs and your upstairs things are going to stay upstairs. Well, if there's a giant hole in the middle of this floor that separates the house, all of your downstairs furniture, your couch is going to be going upstairs, and it shouldn't be. Well, because of that, McRae had this hole in his diaphragm. His intestines came up into his chest cavity, and your body is just communicating and sending signals to your brain and all of that while you're developing. And his lungs bumped up into his liver or bumped into his heart, and they were like, oh, we're hitting other things. We're going to stop growing right now because we have no more room to grow. And so that's what happened. So I kind of try to tell people, think about a micro preemie, like a 22-week, 23-week baby being born. Everybody knows about preemies, or most people do, and they're teeny tiny lungs, need help breathing, and you'll see them just with all these tubes and things like that when you have a friend or somebody who has a preemie. Well, it's kind of like that, except for this time it is a full-term baby, but they have those teeny tiny little lungs and not a teeny tiny little body. They have a bigger baby body because they're full-term, regular-sized baby with those micro preemie sized lungs. They're going to require more support, and we can talk about that too. But I'm just trying to give you a visual of what's happening here. So the biggest issue with CDH is lung development. Typically, when the organs move up into the chest, the lungs don't have the space to grow. Like I said, they can be very underdeveloped, and this is called pulmonary hypoplasia is what you're going to see. Basically, it means tiny lungs, okay? And this affects breathing, oxygenation, heart function, everything's communicating, and it just kind of throws a wrench in it. When you Google it, you see left-sided CDH, right-sided CDH. And then on Google, it's like left-sided is more common, right-sided less common, more severe. And I just don't know about that. I mean, I understand why AI, Google, or whatever says that. But from being in the hospital and seeing these left-sided CDHers and these right-sided, yes, with the right side, the liver is more likely to come up, and that's big. So the lungs can be small, like in comparison to your spleen or something, or your stomach. But those right-sided babies, once they start eating, that's like the last step. That's the signal that they don't say. But once they start eating on that CDH unit, you pretty much get feeds down, and then you're just out of there. And some of those were just zipping on out of there. But I will say, I've seen the cases that are undiagnosed until birth pretty much, I would say, I'm not a doctor, but 9 out of 10 times that's going to be a right-sided CDHer. I don't know. I don't know if it's because the liver's blocking everything from coming up, so you just don't see all these intestines and organs and things in your chest. Why that one goes more undiagnosed, it's easier to hide. I don't know. But I did actually know an undiagnosed CDHer down there, which is just absolutely insane that people could miss that. But they do. Not a lot of people know what to look for. You think they do. Like typically in your anatomy scan, they're like looking at the function of how things are going. It's not common to see someone's liver in their chest. And so, I don't know. You know, it's like being an autopilot and just driving home and you're like, how did I get here? Sometimes those ultrasound techs could just be looking for the things that they're supposed to be looking for and not looking for other things. I don't know. I can't come up with an excuse as to why it gets undiagnosed, but maybe that's that. But yeah, so you see left-sided, you see right-sided. You don't see bilateral. You don't even hear about bilateral. And coming from a mom of a baby with 2 really small lungs, that just like breaks my heart because I wish more people talked about that. So yes, there's left-sided, there's right-sided, and in very rare cases, there's bilateral. And bilateral, you can put 2 and 2 together, 2 meaning bi here. Both lungs are affected. Typically, with CDH, of course, both lungs are going to be affected, but one lung is really affected more than the other. If it's a left-sided CDH, then your left lung is going to be small, and you're going to depend on your right lung to do most of the work. If you're a right-sided CDH, vice versa. But if you're bilateral, both of your lungs are small. So McRae technically got diagnosed with left-sided CDH. If we're talking about my sweet boy, then he had left-sided CDH. So in this case, I'm like, okay, at least we have our right lung going for us. And for some reason, and I don't know if it's still true, but this was the first case they had seen like that, at least what they had told me. But his good lung, which was supposed to be his right lung, was smaller than his left lung. And that was congenital. He was born that way. So even if he, I don't know, hypothetically speaking, never had CDH, he still would have had a small right lung. And we don't know why. We're never going to know why. On paper, it said pleural effusion, which means fluid. There was fluid in there. So because that fluid was wrapped around that lung, that right lung, it signaled to his body for it to stop growing sooner. So he essentially was bilateral. He did not have 2 holes in his diaphragm, but he had less than 15% like lung volume on one side, and I think 12 or something crazy, I don't even know, on the other. He had tiny, tiny, tiny lungs. Sorry. When I was down there, we also did have this baby who had a floppy diaphragm, and there was no hole technically in her diaphragm, but it was like a rubber band and very floppy. And so her intestines would kind of bounce up and hit her in the heart. And I never even heard of that. You learn things. You learn things. So let's talk about timeline here. You're going to get that diagnosis likely around your anatomy scan. It's terrifying, especially if you're in a place that doesn't know what to do with CDH or highly recommends termination when they see it, because people think anything that's not normal is worth terminating, I guess. And I don't know why. The good part, if you're going to try to find the good, is you're going to see your baby a lot more. Like my healthy, normal pregnancy, I had my first ultrasound to confirm, like my vaginal ultrasound to confirm I was pregnant. Then I had my anatomy scan. And then that was it. Boom. We just waited on the baby to be born. Like you just barely see your baby. When CDH happened, you're getting scanned all the time because A, people want to learn, they're obsessed, and B, they're learning. They are using the data every single scan to prepare you for your future, and they're looking at ECMO risks and all of that. Well, first you need to find a hospital. I highly recommend Dr. K's at Johns Hopkins All Children's. When I first got my CDH diagnosis for my baby B, my maternal fetal medicine recommended me Johns Hopkins, but in Baltimore for the feto procedure. That's where they go in, they put a balloon. Some people will swear by it, and that is great for them. I do not think that was what I should have done with McRae, and I wasn't a candidate anyway because he was a twin and they were not going to risk baby A. I'm not dogging on it. I'm just saying it wasn't for me, and we didn't do it. I can't even talk on it. But I will say, when you do that procedure, that is while you are pregnant. And so anytime they're going in your belly, there's a higher chance of you delivering early. And CDH babies, you want them to be in as miserable as you are pregnant for as long as you can to get as much lung growth as they can get. Oh yeah, you can look up different hospitals. I immediately went to the Facebook CDH support group. There's Tiny Hero. There's now the Golden Gear, which is, or Breathe Between Battles, which is partnered with the Golden Gear, my nonprofit. I got to plug myself there. There's a lot of resources out there. And then there's grants, and that can be in another video, but I'm mostly just informing what CDH is. When I found Johns Hopkins, I called and I got myself in there, and I talk about that in my first episode. So if you want more details about that, you can go there. So let's go back to the timeline that I keep circling back to. Let's say you go to Hopkins, and I'll just tell you my situation. They're going to want you there early because you don't want to deliver a CDH baby at your hospital or anywhere else besides in the center, because some of these babies need to be on ECMO, which is the highest form of life support, immediately. Most of them need to be intubated pretty much as soon as they're born, which is also life support in the sense of it is fully doing the job of the lungs, whereas ECMO is doing the job of the lungs and the heart. That is why it's considered the highest form of life support. Some hospitals don't even have an ECMO circuit or don't have the right size things to intubate a teeny tiny little baby. So yes, find the hospital that you need to have a plan. And what I would do, if you can, find a Ronald McDonald or try to live as close as you can to that hospital. Because if you're like, oh, well, it's only an hour away, are you willing to risk that hour for your baby? Not knowing how long they can breathe without life support, Think about that. So it's the day the baby's born. Depending on the severity of CDH, it is a spectrum. But you're probably not going to hear your baby cry. And you're very likely to have your baby immediately taken away. So your birth plan, just let it go. And I'm sorry, but keeping them alive is more important than your birth plan. I am all about crunchy baby born in the bathtub. Just please get an anatomy scan is all I'm saying. First things you can do if you're spiritual, obviously ask for prayers. Get the prayer chain going, get the information out there, get to your hospital. So you're not going to hear them cry probably. They're immediately going to be taken away, put on ECMO or intubated. Intubation is the ventilator, which I talked about, life support. And most CDH babies start there, and that helps their lungs rest and grow. And this is the point that I call the 4th trimester. Remember when I said like they're a micro preemie but a big body? Think about it like that. So we kind of have to incubate them for a little bit. We kind of have to trick them into thinking they're back in mom's belly for a little bit. And so instead of the placenta breathing life into them, it's a ventilator or an ECMO circuit. And just like being pregnant where they're learning how to breathe and they're doing all these little exercises, that's what they're going to be doing outside of you. It's just like a 4th trimester. And maybe that even works for timeline. I don't know. Sometimes it does for some people, sometimes it doesn't. There is no timeline. If you're wondering what the timeline is, keep wondering because some babies are out of there in 17 days, which is the craziest thing I've ever heard. And some babies are out of there in a year. It is a spectrum. Typically, they're put on a ventilator. Some need ECMO. My sweet little boy needed ECMO. That was heart and lung bypass. It gives the lungs a chance to rest completely. And it also does the job of the heart. It takes blood outside of your body, oxygenates it, puts it back into your body. And that's pretty much the simplest way I can put it. I could talk about ECMO absolutely all day because I'm obsessed. But that'll take a whole episode. Then there's surgery. Some babies get surgery, especially if they're put on ECMO, I would say, because you kind of blow up like a balloon rather quickly. Now, I have seen a baby at different centers have their repair surgery at like 2 weeks old. But I think Dr. Case just wants to give those lungs as much room as they can possibly have, get those intestines where they are supposed to be, and just get the ball rolling. I don't even know how long surgery would take. I mean, we were told like he'd be there at 8 o'clock in the morning, and I didn't get to see him until like 10 p.m. His surgery was not going on that long, but there was just different things, and I don't know. I was so out of it, and a lot of my memories of McRae are just like looking through a dirty kaleidoscope. I just can't. It's all fuzzy. During surgery, they pull the intestines down and they put a little patch, like a cute little patchwork quilt of your diaphragm. And you can see it, and they'll take pictures, and they patch that little hole. And surgery, honestly, I would say is the easiest part of this for the baby. And then they got to start working after that. After surgery, you're like walking down the vent is what they'll say. You're trying to find this healthy balance of vent's doing most of the work. Oh, baby's starting to do some work. We're going to turn the vent down. Baby's starting to do a little bit more work. We're going to turn the vent down. And you just walk it down as quickly or slowly as baby needs. And then you try to get extubated. And I can speak on this part a little bit, but I didn't get to this part as quickly as others. And just in general, sorry. And also ECMO, same situation. You got to walk it down. ECMO circuit's going to do absolutely everything at first. And then you kind of walk it down. And then it's step 1 if you need ECMO. If you don't need ECMO, then ventilator step 1. But then if you do have ECMO, you get off ECMO, then you go to ventilator. And you see what I'm saying? And then it descends from there to getting extubated, where they'll take that tube extubation that again, I'm just going to put this in simple human terms. That tube's going down their throat is what you'll see. Like when when you're watching an episode of Grey's Anatomy and somebody's like pulling the plug and they're just not moving and they have that huge tape and thing on their face. That's a ventilator, and it's like pushed down their throat and pretty much going into their lungs. So that'll get taken out, and then they'll have a cannula pushing oxygen up through their nose, most likely. And then you get into like CPAP and high flow and then room air. A lot of the babies leave the hospital on oxygen. It's not for life. Some of them, they're off of it after 30 days. You have to do it if you're flying back. Just they got to get used to breathing earth air after. But that's the timeline of support, I guess I would say, specifically oxygen support. Back to general stuff. You're not going to hear them cry. You're probably not going to get to hold them off the bat. Yes, you can say, well, my cousin Sally had a preemie and she was holding her preemie baby very soon, or intubated baby soon. I don't know if it's just specific to where I was at, and maybe it is. Maybe because they're more fragile. I don't know. And this is definitely a triggering thing for me to talk about because I did not. It's never enough, but I definitely did not get to hold McRae as much as I wanted to. He was born in September, and I held him for the first time on Christmas Day. No, it's not the case for everybody. He was very unique in the sense that he was on ECMO for a really long time. And I know it's hard because it's just the most natural thing to want to hold your baby. So that does get taken away from you. There's not another way for me to put it. Yes, you can be douchey and big picture and say, but my baby's health comes first and keep telling yourself that. But it's still freaking hard. I'm just going to be honest. It's really hard to not hold your baby. So yeah, you can help. You can do like linen changes and pick them up, but you can't like walk around with them, pat their little butt, smell their hair. That's just not a thing. Yeah, so it's very unfair. That's a huge unfair. That part sucks about the CDH journey. But your touch still does matter, and your nurses are incredible. They're gonna teach you. You can do the butt pats. You can squeeze. You can apply pressure. You can rub their little face. Give them a foot massage. You can touch your baby. You can't just freely walk around with them. And you will find a way to bond. And your nurses will help you. They've done this a million times. They will help you. So some CDH babies post all of this oxygen stuff. You're finally holding them. They're finally learning to eat. They're probably going to have reflux. They're not used to. Their GI tract isn't used to being where it's at right now. And it didn't do that thing that I was talking about with gastroschisis earlier where it formed outside, flipped, did a little thing, went back inside the body, and was where it was supposed to. So it's just out of whack. And they also didn't immediately get that, golden hour on the boob or instant formula that most babies get. You got to train them how to breathe. You got to train them how to eat. You got to train them how to do everything. So some babies eat. They slowly start learning, and you're giving them like milliliters, just so you know, like 5, something crazy when you first start. And then if it's not working, if they're throwing up a lot, if their stomach especially was up in their chest, then it probably was shoved up into their esophagus, and that hole towards their stomach is just really big. So then they're probably going to get this thing called a Nissen. And they just, in the most simple terms, kind of make that hole that is creating all this reflux where stomach acid is bouncing up into their esophagus, and then they're throwing up their food. They're just going to, or sphincter, I guess is what they'd call it, make it a little bit tighter to where they won't do that. And some babies can't throw up at all after they get this procedure. Most of the time when they get the Nissen, you're going to have a G-tube. And then your baby, if they aren't traumatized from all the throwing up, they can still keep eating by mouth, but some of them get fed strictly on the G-tube. And some parents absolutely love it because then their kid's sleeping through the night and they're just getting their tube feeding at nighttime and waking up with a full belly and not waking up. Now, again, I'm trying to joke and find the good in all of these things. That's not for life. Most G-tube babies, I don't want to say most and speak for a G-tube parent right now. He's like, that's not true. But a lot of my standard CDH friends, babies, whatever, they got that G-tube out rather quick. Some before they're 1 year old, some by 2, some at 8. You know, sometimes it is for life. And you have to know that, but it's typically not for life. And then there's different types. There's like G-tubes, GJ. But this is about CDH, so we're just going to talk about CDH. That's that. Oh, also, my other twin had severe reflux too. And reflux is just no joke. They're probably going to be on medicine. They're probably going to be on that medicine for a while. I can't speak on that. I didn't get the post-hospital experience, so I'm sorry. But good news is this podcast is going to continue on. I'm going to talk to my other CDH friends, and you can hear all about that, and I will ask all those questions. So if you have questions, please let me know, and I will definitely cover those things, and you will get a primary resource who can give you a better answer than my hypothetical future here that I never got to have. I'm trying to think of other things that happen. Okay, so ECMO stands for, I don't know, some big word, like extra corporal membrane oxygenation or something like that. I don't know. But it's heart and lung bypass. Blood's taken out of the body, oxygenated by this machine and returned. Like I said earlier, it is life-saving. It's also high risk. And it was the love of my life there for a little bit because I learned so much about it. And I will fight for ECMO forever. So many people, and I know they're not intentionally trying to hurt my feelings, me personally, Chloe, but so many people, especially on that CDH support group, are like, oh, we didn't need ECMO. Thank God. I mean, yeah, that's great that you didn't need ECMO, but I'm not a hater of ECMO at all. And some babies probably should have gone on ECMO and didn't, and it made them have a longer hospital time. Yes, it's scary. Yes, you hear about the risk of stroke. But I know for a fact if McRae did not go on ECMO when he did, he would have died. He just was so critically ill and unstable. And McRae got off ECMO. Whenever I tell people how long McRae was on ECMO, they just assume he died on ECMO. No, he lived off of ECMO just as long as he lived on ECMO. So anyway, yeah, so the risks include bleeding, stroke, clotting, infection, and challenges coming off. Some babies, when they try to get off ECMO their first attempt, within an hour, they're going to know if they need to go back on or not. And I don't know, this is just me, but I feel like it's easier for a baby to get off of ECMO than it is a grown person because we've lived a whole life. Our body has suffered a lot of trauma of, living and typically if you see somebody old on ECMO try to get off, their body's like, ooh, I have to do all the work by myself again? No, thank you. So those babies are resilient. They've only ever been sick. They're sick inside you. They're sick when they're born. They are born fighters, and they're going to fight, and they're going to try their freaking best to get off ECMO, and they're going to try their freaking best to get extubated. They do. They want to live. They do. And the things they can take is insane. I know I'm all over the place, so I'm just trying to think of everything I can think of right now. And, it's emotional. It's hard. So what I like about J-Hop in St. Petersburg, Florida, is how Dr. K's does ECMO. And I can speak to another CDH mom if she wants to talk about it. Because I'm in North Carolina. Yes, Duke is a thing. Yes, Levine's is a thing. Still don't think my CDH could have been born at either one of those places. Incredible, incredible hospitals. And you're going to hear some heart kids, especially with Levine's. They're going to be like, yeah, well, Levine saved my kid's life. And it probably did. Your heart kid. CDH is different than CHD. And they're great. And sometimes I think what would have happened had I had my CDH fixed and then McRae was a cardiac kid as well, if I would have gone to Levine's after and transferred, how would his heart have been handled? I don't know. But a lot of times when you see babies on ECMO at other hospitals, they're pretty much, they're given rock. I can give you the full names for everything, but I'm trying to put this in simple terms, like I said. And that pretty much paralyzes them, completely sedates them. They can't move a finger, can't even blink. And you'll see their eyes taped shut. And that is just let the machine do the work. And that's what ECMO does. It does the work. But what I like about how Dr. K's does ECMO is he wants the babies to do the work. I mean, it becomes like physiological. He's training their brain to want to fight in them, and he doesn't fully 100% sedate them. McRae was on ECMO and was rolling. I mean, he's not walking around. He's a baby. Baby can't walk for a while, but he was moving. He could hold my hand. He responded. He moved his eyes. He was a little wiggle pants. If you're friends with me on Facebook, you've seen videos that I post of him. But yeah, he kept them more awake. And his philosophy is that babies need to fight, they need to breathe, they need to participate in their own recovery. And it's incredible. My friend who had a baby at Duke, and this is how I know McRae couldn't have been born there. Duke was like, all right, we're only going to let your baby be on ECMO for 30 days because they believe it's unethical to extend it if there's no change and no positive, that the baby doesn't show signs of getting off. They're going to not want to keep that baby on anymore. And that's awful. McRae was on ECMO for like 68 days, and he got off of ECMO. And if he would have been at Duke, he would have died because Duke would have just given up on him. So now that's not normal. I would say like they try to keep your baby on ECMO like a week or less, maybe 2 weeks. But yeah, so they would have kept him completely sedated up there, and he just would not have handled that well. I really like how Dr. K's team does ECMO. They're very strategic with it. They don't automatically put a CDH on ECMO. They assess the whole picture first, and they can tell you your ECMO risk. So funny, actually, because McRae he's like, I don't know, 50-50, and it was probably 100% because he was on ECMO probably quicker than they've ever put a baby on ECMO before. I think they were cannulating him, putting him up on ECMO as soon as they got him up the elevator. But yes, he prioritizes babies' stability before their repair. I'd say he gets them on ECMO. If they need to be on ECMO, then he's like, all right, let's plan this repair, and then he'll do the surgery. He just waits till they show readiness. His team is highly specialized. There's respiratory therapists, there's surgeons, there's nurses, there's ECMO, there's perfusionists, there's a whole bunch of people. There was probably 30 people in that room whenever the twins were born, so modesty just goes out the door. Lottie had a team because actually my twins had to be born because baby B, that's McRae, obviously had CDH, but baby, his sac was just so big. He had like 4 times the amniotic fluid, but Lottie on her BPP, on her ultrasounds where they're like checking to make sure the baby's breathing inside you, she wasn't breathing like the last 2 ultrasounds. So they're like, yeah, we gotta get her out. So she was actually my problem child. And I always wonder, had McRae stayed in a little bit longer, like would he have been stronger, what he would have been like when he was born. You're gonna be there for a couple months. You're gonna be there about a couple weeks to a month before your baby's born. If you go to JHOP, say in Ronald, then you're going to be there the whole time. You can be in that room. You get your own private room. You get your own bathroom. You can sleep in there if you want to. I would have had I not had his twin sister, and I did for 2 hurricanes. But, yeah, you can be in there as much as you want. So several hospitals have it. I know CHOP has one. I don't know if these are true. I just have these written down from hearsay, but like UC Davis, Denver Children, Vanderbilt, Texas Children, Cincinnati. Every center has a different philosophy. Some are more aggressive. Some use ECMO more. Some use it less. Some push FETO. Some don't even touch ECMO. And your baby does have to be like roughly 4. I think 4 pounds is the minimum. And that's not like, it's not really a weight thing. It's more of a vasculature thing. Like how big those cannulas are big. They got to be able to fit them in the baby. So NICU life. If you're new to this diagnosis, you're going to hear new vocabulary words every single day. And the stuff that you think you're like obsessed with while you're pregnant, I think it's like a LHR. That doesn't even matter once the baby's born. Like people, I remember we were going on this Facebook page and we're like, my LHR was like 0.8 or something. I don't even know if that's even, if I just pulled that number out of thin air or what. That you don't need that once your baby's born. That's just not a thing. Then you're going to start talking vent settings. You're going to understand like FiO2 and what your oxygen's at and how many breaths per minute your ventilator is doing. And knowledge to me is power, but some parents It's not. It causes more stress and more anxiety, and they just put their full trust in their medical team and in God, and that's great. If that's what works for you, that's great. I'm obsessive. I need to know every single thing going on, and it calms me down because not knowing, I'm filling in gaps and I'm just making up stuff in my head. So I needed to know everything that's going on. You're going to wait for numbers like blood gases, oxygen saturation. I mean, it's like fresh off the press or fresh out the oven or whatever those expressions are. You're going to know what it means. You're going to want them to be certain numbers, and then you're going to learn what that, whenever his gases were good, I'm like, oh, he's breathing on his own. Like he's ready to come off ECMO. Oh my gosh. We would have I would pin them up on my wall, and the nurses working that day, they would try to get the best gas that day. So we'd make sure he was just in the perfect mood, perfect situation, not mad, didn't just get upset, didn't just do a diaper change or a bath where he would be pissed and the machine would do more work for him. And it just became a little game. You're going to have good days and you're going to have really hard days, and you're going to go 2 steps forward, 7 steps back, and sometimes in the same day. That's normal. You will feel completely helpless, and it's so hard, especially as a mom. But you're also the most consistent part of that medical team. So show up, go to morning rounds, go to evening rounds. Do not be afraid to ask a question, and don't be afraid to say, hey, like whenever Weenie came off of this medicine, I'm like, can we just stop for a day and give him a break? And they listened because you have to be a mama bear sometimes. And he just needed a break. Sometimes it's hard to wean off of medicine. Of course, the big picture, you want to wean them off everything so you can get them home faster, but because you are there every day. Sometimes you'll get a nurse 3 days in a row, and then you won't see that nurse again for like 3 months because she'll just be on different patients, or there's male nurses too. But be consistent so you can help. Yes, I had other kids. I understand that. It is impossible. It's just good to have somebody in there if possible. Celebrate tiny wins. Celebrate blood gases. Celebrate being alive. Constantly, I was told he was going to die when I was pregnant, and then I was constantly told he could die once he was born. So we celebrated every day we had with him. Learn how to advocate. I can help you with that. You can read my blogs. We can talk. I'll talk to you personally. The support group is really good in helping advocate. The nurses are amazing at teaching you how to advocate. And you could listen to my last episode because they crushed it. You're going to grieve. And people associate grief with death. You can grieve while they're alive. Your birth plan was thrown out the door. You didn't hear them cry. You didn't get to hold them. You don't get to tuck them in, snuggle them. You don't get to breastfeed off the bat. Some CDHers do. That's not completely out the door, just so you know. They do get to breastfeed. I've seen it. Or at least a lot of the moms are pumping and, feeding their kid their breast milk through a G-tube. But that's going to be hard, is missing your baby while they're sitting there right in front of you, while you can touch their little feet and grieving the what could be. But it's not machines for the rest of their life. They're CDHers who are playing football. So many people see these machines and then they just think they're like a vegetable, and they're not. You're going to be exhausted. You're going to be scared. You're going to be hopeful, and you're going to be proud. And these are all going to be happening at the same time in your head. Get a palliative team. Palliative does not mean death. They are, oh my goodness, they're incredible. I love his palliative team. Palliative, however, tomato. It's not death. Whenever I told my family that he had one, they were all preparing for his funeral. And I'm like, no, they're going to help you. They were putting stuff in plain English for me to understand. Get to know your social worker there. Hopkins was so good by having a, psychologist come up, and she was incredible. It was just so, I had so much support. And sometimes you don't know you can get that support. So ask and you'll get it. Make a support system. Find other CDH parents. Talk to me. Do whatever you have to do. You are not failing. You're listening to this, you're not failing. If you're listening to this because you're supporting me and McRae, Thank you. I love you. If you're listening to this because you just got a CDH diagnosis, I'm here. Let's fight this. Let's do it. You are becoming a NICU parent, and NICU parents are so strong. Look at how strong your babies are. You created that. Where do you think they're getting that strength from? I want you to hear this clearly. You're allowed to be overwhelmed. You are allowed to cry. Sorry, I'm clapping. I know my microphone probably picked that up. You're allowed to ask the same question 10 times. Do not be embarrassed. I promise you, your nurses do not care. It is their job to save your baby and to help you keep your sanity and answer every single question. I ask the same thing over and over and over again. You did nothing to cause this. It is called congenital diaphragmatic hernia. Congenital. You didn't eat the turkey sandwich, didn't do it. The sushi didn't do it. The hot bath did not do it. In very extremely rare cases, it might be a syndrome or a genetic thing or inherited thing that's on like the male side of the family that could possibly happen, but most of the time it is spontaneous. 99% of the time it is spontaneous. And it's just absolutely random, and it's nothing you did. I'm going to tell you that forever. You didn't fail your baby. You listening to this, you didn't fail your baby. You finding a center for CDH, you did not fail your baby. You go into maternal fetal medicine, you did not fail your baby. You're not failing. I promise you. No matter how scary this diagnosis is, CDH babies are some of the strongest fighters you will ever see. You are stepping into a journey that you never wanted, but you're not stepping into it alone. I could go on forever. This podcast is getting a little bit long, so thank you for listening to this episode. Breathe between battles. If you are walking the CDH journey now, I'm holding your heart with mine. If your baby is in the NICU or you are preparing for delivery, I am lifting you up and I am covering you in prayer. And if I don't know your name, I'm praying for you anyway. I pray for all the future CDH babies. I do. And I'm interceding for all of these CDHers. And there's so much more. So much more. Please share this episode with anybody who needs it. You're not alone. You are loved, and you are doing so much better than you think. And if you want to reach out to me, it will take me 3 to 5 business days to get back to you, but I'll try my best to get back to you. I promise. I'm getting better. I'm trying to get better at least. Okay. I hope you have a good day, night, drive, whatever you're doing. Thank you for listening.